So I'm Dr. Kosmas, and my task here is to show you a live-in-a-box THV case, and a second case if we have enough time. So we start with a live-in-a-box THV case. It's about a male 70-year-old with gradual worsening airflow dyspnea. About his past medical history, he had undergone surgical correction of subvalvular aortic stenosis, arterial hypertension, dyslipidemia, splenic lymphoma treated with immunotherapy, chronic atrial fibrillation, moderate pulmonary hypertension, and elevated risk scores. About the screening core, there is an absence of severe coronary artery disease. And in the screening echo, we can see ABV max at about 4.17 and with moderate severe aortic regurgitation. Here you can see the measurements from the screening echo and some videos with the moderate to severe aortic regurgitation. We have the measurement from the CT angiography. It is a tricuspid aortic valve with mild aortic valve calcification, and we have promising coronary heights, and here you can see some more measurements from the annulus, the LVOT, and the coronary heights. And the distribution of the calcification in the aortic annulus. As for the femoral access, we have a promising femoral access from both femoral arteries, and only mild calcification observed in abdominal aorta and right and left common iliac arteries and right femoral artery. So our strategy here is that the heart team of our hospital decided that transcatheter valve implantation should be the optimal strategy with a Myval 24.7. Here is some procedural steps: light sedation, right femoral artery and right radial artery with echo guidance. We advanced sheaths, 6 French, 9 French, a Python, 14 French, Myval 24.5 without predilation, and the sheath from the sheath 7 French, epictale 5 French to the aortic root. So we can start here, our live in a box, and I comment some high points. Here you can see the right radial artery. We put the 7 French sheath. And next, with echo guidance, we proceed to the right femoral artery, as you can see here.
So, Elias, I think that there is some calcification, especially some posterior plaque, as you can see in the cannulation of the artery.
So we proceed next. The preparation of the sheath, the Python sheath. You can see here, and we continue with the prostyle plantation. You can see here.
So this is the new Python sheath?
This is the new Python here. And
so
now,
yes, so this is one of the valves that maybe someone would be reluctant to place a self-expanding valve. It's a AEI mostly with less calcification. So maybe a balloon expandable valve in these situations. It's a better bet.
We see here the preparation of the valve. And now we have advanced pigtail in the aortic root. We perform our first angiogram. And then AL.
Okay, so this is the usual procedure. So you can scroll a little bit.
I know the wire.
We do ballooning, yes. You can go forward, I think. You can proceed. Okay. So this is the sheath, which is advanced.
You can see here.
As I said, sometimes it's not easy to advance the sheath. Okay, you can proceed.
So we can see further preparation of the valve here.
So this is the Innovi SX, right?
Yes, Innovi
So,
SX.
which is somewhat stiffer than the Safari, which can be used, of course, in this situation as well.
Now we're ready for the valve. The valve is in the aortic root. First injections. Rapid pacing through the stiff wire. Oh, sorry.
Okay. So someone would say maybe it's too risky to to pace through the wire and with a balloon expandable valve. Vlasi, what's your practice? Do you pace through the pacing wire or through the?
Almost always do we pace with the pacing wire unless there is a pre-existing RBBB, and then we put a temporary pacemaker. It's very easy to manage, and even if you get the unfortunate event to get some heart block, you still have time because you can keep the delivery system up to the ascending aorta, continue pacing, and then you have the time to deal with that.
Yeah, good. And this is a good result, and then we did a balloon, I think, on the femoral as well. So, Elias, I think you can share the other case as well.
Yeah, here is the final echo with low mean graded about 9 millimeters. And the second, it's a valvulus valve THV case. It's about a female, 77-year-old, with gradual worsening of dyspnea and recent hospitalization due to pulmonary edema. About her past medical history, she undergone SAVR with endocarditis magna is 21 millimeters at about 15 years ago. The magna is a fracture valve with pericardial leaflets and leaflets suture inside the stent. Elevated risk scores, absence of severe coronary artery disease, and elevated gradients. So here is the screening echo. elevated aortic valve gradients. The screen color, here you can see the relation of the coronary origins with the Magna-East valve. So we're expecting with the measurements from the CT angiogram right here. You can see here that is aortic valve invalve with low coronary heights. The right coronary height is about 4.7, and the left coronary height is about 4.6. And very important, VTC for the right coronary artery, it's about 6.4, and for the left coronary artery, it's about 4 millimeters with the Myval 20. So we proceed.
So it's a very borderline, the VTC to the left, from the right we are fine, but you see the height of the STJ is very low. So we were risking to have an effaced Valsalva, so that's why I think the idea to use a balloon expandable valve in this situation is the proper one.
We can see favorable femoral axis and the calcification of the aorta and the right and the left femoral bifurcation. Myval ideal placement at about 15 to 20 below the fluoroscopic marker in the skewing ring. And our choice here is Myval 20. And so we proceeded to light sedation, right femoral artery puncture and left femoral artery with echo guidance. From the right femoral artery, we advanced seeds, 6 friends, 9 friends, Python, 14 friends, and the navigator delivery system for the Myval 20. And from the left femoral artery, a sieve, 7 friends, an EBU guide catheter, 3.5, 6 friends to the left coronary artery, and stent implantation, chimney technique 4.0, and post-dilatation balloon with Atlas, 20 to 40 millimeters, kissing balloon with the balloon of the stent. So you can see some images here. We have the stiff wire, which is a Landerquist, I remember.
Yeah, it's a Landerquist, yes.
It's a Landerquist wire.
So we use in most of the valve cases, we use a Landerquist wire. So I don't know, Vlasi, what's your practice? Even with the balloon expandable valve, one could use, I suppose, the Innovi, but you have, I think, more accurate control with, even in this situation, with the Landerquist.
I totally agree, as long as you're very careful and respectful of the wire, because obviously it's a stiffer wire, it can do damage, and experienced operators like yourselves can handle it. I would definitely use it if there is a horizontal aorta. We've seen it that tracking the valve down, even the balloon expandable, through the valve in a horizontal position, without a stiff wire, it's a problem. And sometimes it's easier to cross having the deflection mechanism still on. So, for example, in this particular, where you track the valve down over the wire through the prosthetic valve, in some of these horizontal aortas, we used Landerquist, and then we kept the deflection on, and that really gives you a push, up, and it goes through the valve.
Okay, that's a very nice tip. Okay, so
we have already advanced the stent in the left coronary artery. Is a Zions 4.0. So we move on.
And you see the importance of having the correct wire here. It's not easy to advance the valve inside. You can do a correct maneuvers. So I think it's...
Yannis, can you hear me?
Yes.
What is also interesting, and we've had it on a couple of cases, that we didn't use a Landerquist and we used a different wire. You know, you can still take this valve out and change your wire, which is very, very important. And that's the beauty of having a valve preloaded on the system.
Definitely.
You don't have
I
to
think this is
unblock
very
everything
important. The very, very important point. So you can get out, you can take the valve out if you cannot cross. Okay, and this is...
So there's the implantation time here. We implanted the valve. We perform some checks here. And now it's time for the stent implantation.
So, so in this situation, we placed, we didn't see any deterioration at the ostium of the left main, and most of the times we leave it as it is with the self-expanding valve. But here in this situation, we felt that there is still danger of acute closure of the, or a delayed closure of the vessel. That's why we did a chimney technique, but it's sort of a chimney. It's like an orthotopic placement of a stent. So would you do otherwise, Vlasi? Would you leave it alone? And
I think you did the right thing. I mean, better be safe. You know, having a closure of a left main, you know, a couple of hours later is not a joke. And I think you're really safer that way. I have a low threshold if in doubt to put a chimney. It's such a simple thing.
Yeah.
And really having a balloon expandable valve in valve, as you said, it's a short chimney. You don't have to go very high up. So you have less of an issues with access later and dual antiplatelet.
And we have Dr. Mastrokostopoulos. You have experience with the Myval. Would you do that? Would you do otherwise? Press the microphone, please.
So I will probably do what you did. What Vlasi says, it's better to be safe. It's a short chimney, and I think the result is excellent, but we would probably implant a stent here also.
So we move on, we take some measurements, and we decide to post-dilate the valve with a final kissing step. As you can see here.
So we measure the gradient, and I suppose we need to...
So absence of regurgitation. The final result, absence of peak-to-peak gradient, and the discharge echo with a max gradient below 20.
Okay, so this is good. So thank you, Leah. So just before finishing this this symposium, just to show a couple of slides, can we?
Yeah.
Can we have? So this is a satellite symposium. So it would be nice to inform you for two running randomized studies from that we are implicated in. It's the baseline study, started maybe 3 years ago, Ilya. So it's a randomized study. The PI is Nicholas Vamigem from Thorax Center, and we just showed today one case enrolled in a baseline study, treated with a Sapien valve. So basically, it's a randomization between balloon expandable valves and Sapien or Myval compared to the self-expanding platform of Evolut R. So it includes 440 patients, randomization 1-to-1, bioprosthesis You see that there's the primary endpoint is the device success. The co-primary endpoint is mortality, disabling, stroke, hospitalization for heart failure or valve problems. Their patients need to be more than 65 years old, and the VARC-3 criteria have been employed. And of course, exclusion criteria is the presence of the mechanical valve, and there was an amendment recently in the protocol, and now the balloon expandable valves that they're being implanted are Myval as opposed to Sapien. So the device success is defined as the composite of absence of procedural mortality, technical success, it's freedom of mortality, successful delivery of the device, correct positioning of the single prosthetic heart valve, and freedom from surgery or intervention, and the intended performance of the prosthetic heart valve when we don't have severe patient prosthesis mismatch, which is the definition of less than 20 millimeters of mercury in main aortic valve gradient. So these are the centers. In North America and Europe, there are 2 centers. In Greece, Iakovou Hospital hasn't drafted any patients, but we are in the top 3 recruiting centers, you can see on the right. So this is a very interesting study that will give us, I suppose, very important information regarding the use of one platform or the other in the treatment of the valve-in-valve cases, which, as Dr. Dvir showed very elegantly in his presentation, they will be more and more in the near future. And the other study that we are starting now, it's the Start Young study. I think it's very interesting, and it's going to give very important information in this young cohort of patients between 65 and 75. Now they're excluded from the current European guidelines, but you know, we know that in the practice in the States, and Dr. Dangas gave us very important information why this happens is because of the Medicare regulations, and of course also it's how you translate the information that you get from the results of the studies like the Part 3. So these are the PIs of the study, Didier Tsetse, Philippe Garot, and Vinny Bapat. And this is the clinical event committee, of course, and the trial administrator is Marie-Claude Maurice. And we, with Dr. Hamo Georgakis, who is the PI of the surgical arm. This is the breakdown of the study. It's one-to-one randomization, 1,100 patients randomized to Myval or SAVR, patients with symptomatic severe aortic stenosis, age 65 to 75, and the primary endpoint is a non-inferiority safety endpoint at 1 month according to the VARC-3 definitions, and the efficacy endpoint at 1 year of, again, non-inferiority. The composite of all cause of death, any stroke, rehospitalization for valve-related event. There's going to be a CT image in some study. The primary endpoint of it would be to evaluate the prevalence of visible redo TAVI or valve-in-valve TAVI, and the secondary endpoint, the visibility of redo TAVI or valve-in-valve. Of course, they're going to look in percutaneous heart valve hemodynamics and the commissural alignment, and you can see the breakdown of the sub-study, around 500 patients. There are 114 sites from 22 countries across the globe, and we are happy that we are going to contribute to this very, very important study. So thank you, everyone, for being here in this late hour for the Satellite Symposium. I think it was very important to have you here, and there are 154 also colleagues that they're watching the streaming. So please stay tuned for the last session, which is going to be the some Friday's vignette presented by colleagues from Onassis Hospital and other hospitals as well. So thank you.